So I'm going to move on to talk about automated insulin delivery. We're going to start thinking about the evidence for technologies beyond real-time CGM, think about who might benefit from access to AID, explore the importance of choice, and look to the future. But I want you to start by going on a journey in your car with your sat nav, but you're only allowed to look at it 4 times. Not ideal, but this is what finger pricking is for people with diabetes. We want to have all the information, but we don't. You want unlimited views of your sat nav, and this is what real-time CGM does for people living with diabetes. Guess what? Cars are moving on. We're moving slowly towards automation of your car to the point that you may not have to interact as much. But guess what? In diabetes, the same is happening. We are moving towards automation of insulin delivery and accessing this for people living with diabetes, and it is absolutely life-changing technology. Here we have a recent systematic review and meta-analysis from 22 randomized controlled trials, showing that with automated insulin delivery, we get significant improvements in HbA1c, time in range, hypoglycemia, without an increase in the risks, and most importantly, from my perspective, it reduces the burden of living with diabetes with reduced diabetes-related distress. If ever there's a context where glucose control matters, as we've just heard, it's pregnancy. And at International Women's Day, I'd like to take my hat off to Helen Murphy and Eleanor Scott for leading on the ADAPT randomized control trial, which has very nicely demonstrated the benefits of automated insulin delivery for women with type 1 diabetes in pregnancy, with an adjusted but mean difference in time in range of 10.5%, which will deliver meaningful differences for the mother and baby. But to put this in clinical context with a case, here we have somebody presenting in pregnancy with an unplanned pregnancy, which unfortunately happens far more often than it should do. An HbA1c of 12% on multiple daily injections, but in the context of having not attended clinic leading up to this. They hadn't been monitoring their glucose levels, so in early pregnancy we start on glucose monitoring. You'll know that we are aiming for more than 70% time in range in those tight glucose targets in pregnancy between 3.5 and 7.8, and here we're achieving 22%. We're having to start education with carbohydrate counselling, insulin to carbohydrate ratios, correction factors, encouraging her to bolus before she eats, and we offered her the opportunity to move to automated insulin delivery with the CAM APS FX system. I'm delighted that she took us up on that offer, and within 2 weeks of using the system, her time in the pregnancy target ranges shot up from 22% to 49%. I tell you from my clinical experience, this is extremely difficult to achieve in such a patient on multiple daily injections. We required ongoing optimization, and for those of you that are used to using these systems, a key thing is making sure that that bolus insulin is given before the meal rather than at or after the meal. As with all women with type 1 diabetes in pregnancy, as the pregnancy progressed, we tightened insulin to carbohydrate ratios. We continue to support weekly, looking at diet, looking at insulin therapy and optimization. By 28 weeks, she had dropped her HbA1c from 108 to 50 millimoles per mole. Her time in range has increased from 22% to 65% in what started off as an extremely high-risk pregnancy. But most importantly, she delivered at 37 weeks a healthy baby born by caesarean section. This is what technology is capable of supporting women to achieve. And actually, when I reflect back on the randomized control trial data, there's often a disconnect, particularly with AID, in terms of what I see in my clinic and what the trials are reporting. And that's because real world is very different to the people that are typically recruited to randomized controlled trials. So we looked at the real world outcomes in the UK of people transitioning across to automated insulin delivery. Being included in this analysis, they were on pump therapy, the Freestyle Libre, and had an elevated HbA1c, and we report the data on 520 individuals with follow-up. We looked at 6 months of follow-up data and a range of different outcomes, but I'll walk you through the key take-home messages. So we saw a dramatic improvement in HbA1c, 1.7% reduction, reducing from 9.4 to 7.8%. Time in range improved from 34% to 62%. Now, this may not be as high as what you see in the randomized controlled trials or the wilder real-world data, but the reality is when you take people with very high HbA1cs across to this technology, any improvement is beneficial, and that is a substantial improvement for these individuals. But perhaps most importantly, again, looking at diabetes-related distress, at baseline, 69% felt overwhelmed by living with diabetes and felt like they were failing. At follow-up, only 23% felt that way. But fundamentally, the evidence base that's been developed over recent years, the real-world data, have fed into an analysis by NICE in the UK, who have evaluated hybrid closed-loop therapy and have decided that we should have legally mandated access to automated insulin delivery systems for a range of people living with type 1 diabetes. Those with an HbA1c above 58 millimoles per mole, those with disabling hypoglycemia, and from NICE perspective, that is when hypoglycemia occurs frequently or without warning, so that the person is constantly anxious about having hypoglycemic episodes, despite the best possible management. It's recommended in those who are pregnant or those who are planning pregnancy, and in all children and young people. This is a watershed moment in the care of people living with type 1 diabetes, and I am absolutely delighted to be a diabetologist where my job going forward is just to continue to change lives for the better. And actually, we're also in the era where we now have a variety of commercial systems available, enabling choice for the person living with diabetes to work out what system meets their individual needs. And let's be honest, as healthcare professionals, it can be quite daunting walking people through that journey. There are a number of factors to consider, but it's actually really important that we take our time out to ensure that we do this properly, because these bits of kit are potentially going to be attached to the person for 4 years. So when we look at the sensor component, you want to consider the accuracy of the sensor, the size, how long is it worn for, where on the body can it be worn, how easy is it for that person with diabetes to use it. When we look at the actual hybrid closed-loop system and algorithm, what's the evidence base underlying that system? What's the license? What populations is it available for? What's available with your local funding arrangements and in your country? And is there phone compatibility issues to consider? Then when we think about the pump, we're thinking about the size, the interface, how we update the software, the set changes, the cannula types, the reservoir size. It takes a while to go through these things, but we have to ensure that people with diabetes are equipped with information about this so they can make informed decisions. Now, it's beyond the scope of this talk, but in the UK, we've developed a best practice guide, which has very practical recommendations about supporting people transitioning across to hybrid closed loop therapy, which is open access. So please do Google DTN best practice guide, and you'll be able to access this to look at. So I want to quickly do a survey. We've got many countries in the room. Let's explore what access you've got. So this is Laura, who's 48 years old. She's got type 1 diabetes and multiple daily injections, and her HbA1c is elevated at 67 or 8.3, despite education and access to real-time CGM. In your country, could you access automated insulin delivery for this person living with diabetes? If you can submit your responses now as a yes or no, and we'll see what comes through in the word cloud. So it looks like the majority of the room are a yes. Definitely. I like it. Wow, that's inspiring. So the majority of people, by the looks of it, will be able to access automated insulin delivery for this person. Okay, I'm moving on to the next case. So again, we've highlighted the importance of glycemic control in pregnancy and access to the best support. So here's Katie, who's 26 years old, type 1 diabetes, unplanned pregnancy with an HbA1c of 67 or 8.3%, despite multiple daily injections and access to real-time CGM. In your country, could Katie access closed loop therapy for the duration of her pregnancy? So submit either yes or no. So again, the majority seem to be coming through yes. Some have got sort of saying private insurance. But again, this is amazing. I'm really excited to know it's not just the UK where we're finally managing to get the technology into the hands of people living with diabetes. So let's look to the future and what the future holds. Well, in terms of the Abbott offering and the systems that are coming through, and again, not all of these systems will be available in all of your countries, but we have the opportunity now to link the Freestyle Libre 3 with a Ypsomed pump with CAM APS. And we also have the Freestyle Libre 2 Plus linking in with Omnipod 5. Now, I'm in the fortunate position to be the chief investigator on the Radiant randomised controlled trial, where we are currently recruiting 200 patients from the UK, France, and Belgium into this trial, which recruits people with a high HbA1c, on multiple daily injections, and on the Freestyle Libre, and then randomises them either to the Omnipod 5 with the Freestyle Libre 2 or the control arm. And I'm very much looking forward to reporting those results in the future, as this is the first randomised control trial looking at those transitioning from multiple daily injections to the Omnipod 5 in both adult and paediatric participants. Now, obviously, I can't share the results of the study yet, it's still underway, but I will provide you with some of the feedback from two of the participants in my study. So, this is, I have been getting on really well so far. I love the freedom that the system gives me without the need for injections. It's very simple and user friendly. I do feel like it has a huge positive impact on my diabetes, and it's undoubtedly changed my life for the better. A total life changer. I feel all the restraints of being diabetic have been lifted. I can now do what I want, when I want, and eat whenever life suits. I don't suffer highs and lows like I once did, and my temperament is much better. I feel far more relaxed with stable, lower blood sugars. My family have noticed the difference in me. They no longer worry about how my diabetes is doing. In conclusion, would recommend anyone to use this. It makes you feel human again. Really powerful words. So, Chair, ladies and gentlemen, in summary, the use of diabetes technologies is expanding rapidly. The changes we've seen in the last decade are mind-blowing. And the next decade is going to be just as exciting as we see the expansion of automated insulin delivery to improve glycemic outcomes, but most importantly, improve the lives of people living with diabetes. The choice of system is important to the person with diabetes. It requires thought and detail. And again, we need to equip ourselves with all the knowledge to be able to impart that to the person with diabetes during their consultation. And we also have a growing number of systems which are offering compatibility with the Freestyle Libre sensors. Thank you very much.